Okay, so we move on to the last speakers. Professor Sun Yihong. She is a professor of medicine, China, Japan, Friendship Hostels, Beijing. The title of her talk is Gender-Specific Prognosis in Acute Myocardial Infarction. Professor Yihong, please.
Thank you, Ms. Chairman. So, dear speakers and the panelists, thanks very much for inviting me to join this very important session. And
okay, I can see.
Yeah, so my topic is about the gender-specific prognosis in patients with acute myocardial infarction. So I'm general cardiologist from the China-Japan Friendship Hospital in Beijing. So personally, I have no disclosure for this presentation. Yes. And so this is data from the United States. It shows during the last 30 years or 40 years. So the mortality for cardiovascular disease has been declined for both men and women. But we can see from the curve that so the women still has higher risk of mortality from cardiovascular disease compared to men. So, so how about the patients already have history of myocardial infarction, and we're looking at the recurrent cardiovascular events. So this also from the American data by 1.4 million American adults. I think this data from the Medicare data, and all the patients are hospitalized for myocardial infarction and followed up for at least 1 year. And this slide shows that the blue one is for men, and dashed pink one is for women. So we can see that the rate of the recurrent myocardial infarction and other coronary heart disease event and heart failure, hospitalization, and mortality in the first year after first myocardial infarction has been declined for both men and women, but the proportional greater reduction for men than for women than for men. So I think it's care for the women is getting better. Besides, I also want to share with you some data in China. So this is the data from the China Peace Registry. So the China Peace Registry is a national registry to the cross-sectional survey in 3 points during the last 10 years in 2001, 2006, and 2011. So from this plot, we can see that the average age of the woman with myocardial infarction increased from 68 years to 22 years during these 10 years. And there's not much increase in the men compared to the women. So how about the care in the hospital? So I'd like to show you the from symptom onset to admission. So this time is very important for the care of the patients with STEMI. So you can see that the proportion of the patients who has proper admission to the hospital, that means less than 12 hours, has been increased, especially from 2006. Although that, but the patients who received the reperfusion therapy for both primary PCI and the fibrinolytic therapy. If we compare this between men and women, we can see that fewer women received reperfusion therapy compared to men. Yeah. So although the woman has more prompt to the hospital, but they're still less likely to receive the optimal reperfusion therapy for those with STEMI. So there's another analysis also based on the China Peace Registry. So this slide shows you the in-hospital mortality after the STEMI between men and women and based on age. So the fingers on the left shows you that the both in each age average, so the incidence of the death risk during hospitalization is higher in men, in women compared to men. And if you look at the gender age interaction, it's very interesting that although we know that the elderly woman has the highest risk of in-hospital mortality, but if you adjust it for all these compounders, you can see that actually the gender difference in the in-hospital mortality was age dependent, but the greatest in the younger groups that younger than the less than 70 years old of age. Next, sorry. Okay. So there's another big data in China to show the gender difference in the in-hospital mortality. So this is from the 3C ISS project that including about 80,000 patients admitted for ACS in China from 2012 and 2018. So the left side shows you that the overall in-hospital mortality is higher in men compared to higher in women compared to men for those with STEMI and the non-STP elevation acute coronary syndrome. And if we look at the reason contribute to the higher mortality for women, you can see that the women hospitalized for ACS has less frequently received acute treatment, the medication, the second prevention medication, and also the anticoagulant treatment or the less optimal primary PCI treatment compared to the men. So the sex differences in the in-hospital mortality was mainly due to the worse clinical profiles and the suboptimal evidence-based acute treatment. So why women has worse outcome compared to men, and if the clinical profiles and the suboptimal treatment can explain all this phenomenon. So we have done a study based on the CPEX data. So the CPEX-3 study is a registry-based stepwise cluster randomized trials to evaluate the effect of quality of care improvement interventions for improving the in-hospital MACEs for patients with ACS. The patients coming from about 100 non-PCI hospitals in China. So the clinical outcome is MACEs at 6 months after discharge, including all-cause mortality, non-fatal MI, and non-fatal stroke. So this is a baseline characteristics. So it is quite obvious that the average age of women is much older than the men, and women are more likely to have diabetes and hypertension as well. So it's very similar to the previous studies. So we also look at the time from symptom to admission. So obviously, women has worse treatment after the admission as well. So if we look at the use of aspirin, the use of clopidogrel, and the use of fibrinolysis, so you can say there's a big difference between men and women. So how about the 6 months mesis according to the age? So the left finger's Kimlin pair shows used for female. For women, the 6 months mesis, the risk of 6 months mesis is much higher compared to men. But if we stratified them according to age, less than 55 years old or larger than 55 years old, that you can see for all patients less than 55 years old, there's no big difference between this men and female with regard to the mesis, but there is a little bit difference between the men and women for those with elderly than 55 years old, but the P4 interaction between age and gender is non-significant. So what's the factors can explain this gender associated difference on 6 months mesis? So we has already classified all these risk factors into cardiovascular comorbidities and risk factors. Obviously, the age is a very important contributor, and we also look at the socioeconomic status, such as if they have any insurance, and there's an education level, and also the presenting status, if they have low blood pressure or very fast heart rate, and also the time to present, and the in-hospital medication treatment for patients with STEMI, if they received thrombolytic treatment. For all these factors, we can see that the most important three contributors to the difference between the outcome is the cardiovascular comorbidities, age, and the socioeconomic status. So all these three factors explain about 70% of all these differences. So there's another very similar analysis from the American data. They also look at the 1 year all-cause hospitalization, and also looking at what is the explanation, what's the factors contribute to these differences. In this study shows that the health status and the psychosocial factors may be is most important for this gender difference. So what's the real reason for the gender difference in patients with ACS? Why women has worse outcomes? So there's some old concept about the difference between men and women. So for women, they only have always have untypical symptoms. They are much older. They have more comorbidities and something like that. So what about the explanation at this moment? Because age is maybe not that important. So there's several studies to look at younger patients with acute myocardial infarction, and the mobility and the mortality. So in this study, they found that young women with myocardial infarction has more comorbidity, has higher in-hospital mortality compared to young men, but they still have worse outcome. But in this study, this is the STEMI registry, including about 100 patients hospitalized and received medical treatment for STEMI. So in this study, we can see that the younger patients with STEMI independently associated higher 3-day mortality, but the sex difference in the mortality declined after the age of 16. So it is if for all patients younger than 60 years old, so we can say that the outcome is still very significant. So the young MI registry also look at the patients with MI but younger than 50 years old, including about only 400 patients with women. So in this study, you can find that there are several interesting findings. The first is that women are more likely to have diabetes and underlying rheumatic conditions. So this has been mentioned by our previous speaker. And women has lower median income and more likely to have public insurance. In other words, maybe the private insurance is low. And for the clinical presentation, the most common presentation symptoms also are all chest pain for men and women, but women are more likely to also have untypical chest pain, such as dyspnea, palpitation, or fatigue. If you look at the management, women are less likely to undergo angiography and revascularization, and they're also less likely to be on the guideline-directed medications that we have been showed before in other studies as well. So women has increased all-cause mortality over about more than about a follow-up of 11 years. So this is a young MI registry. So the other reasons is that maybe there's some gender difference with regard to the cardiovascular medications. So this is a position paper by the ESC published in the European Heart Journal to show the difference of absorption metabolism and the distribution of many cardiovascular medications is different between men and women. And what we have done is to look at if women is resistant to some antiplatelet. So this is the data that has not been published. We're just submitting it to look at the patients receiving dual antiplatelet receptor, aspirin and clopidogrel, and they have some platelet function test. So what's the independent risk for the high platelet reaction? There's after the multiple variability analysis, we can see that only female and renal dysfunction as the independent risk factors for the high platelet reaction. There's another big study to look at the sex difference in the response of antiplatelet drugs. So this the ADAPT-DS study. They also used Verify-Now to test the response to the clopidogrel. So in this study, it showed that the high platelet reactivity was more common in women than in men, but the associated risk of this high platelet reaction for the stent thrombosis was similar in men and women. However, if you look at the bleeding events, you can see that for women who do respond properly to the clopidogrel, have higher risk of bleeding. So it's very interesting. For other situations for the antiplatelet treatment. This study from the Paris study, this is data from the Paris study. In this study, it showed that women has higher rate of the cessation of this dual antiplatelet compared to men in the 2 years follow-up following the successful PCI. And this disruption was associated with increased risk for both ischemic events and bleeding events. So another explanation, I think I will just give a brief view of this data, because I think the previous speaker has talked a lot about microvascular dysfunction in women compared to men. So this study shows that the microvascular dysfunction is significantly related to the masses, although women has lower burden of the atherosclerosis plaque. So the masses was higher in both men and women. For those with low CFR, it means that for low coronary flow reserve. So why this woman has lower coronary flow reserve is not because it's not related to the IMR, not related to the index of the microcirculation resistance, but it is related to the resting dilation function of this in the coronary heart disease, in the coronary artery in women. So there's a just updated review about the sex and gender difference in the cardiovascular treatment and medicine for patients with acute coronary syndrome. You can find it in the European Heart Journal this year, and this review has a very good outline of this difference between the pathophysiology presentation and the outcomes of acute coronary syndrome in women and men. So for the sake of time, I won't go through all these details. So for summary, a woman with ACS has less favorable short-term outcomes as compared to men, particularly for those with STEMI. And this gender-specific data on long-term mobility and mortality are relatively conflicting. Studies report consistently worse short and long-term outcomes in younger patients. So this is, has been shown in many papers and recently. We need to know the cause of the worst outcome for women, although it is very complex to relate to the coronary biology, to the socioeconomic factors, and to the medication response, and something we need to we need further investigation. So thank you all. That's my presentation.